My name is Veronica Winget. I'm a third-year OBGYN resident at the University of Arizona. My project is on the role of a resident in laparoscopic sacrocolpopexies. This is a minimally invasive advanced urogyn procedure performed for pelvic organ prolapse. Women in the United States have about a 20% lifetime risk of requiring a urogyn procedure. Studies have shown that academic medical centers with trainee involvement have decreased mortality rates for hospitalized patients, but the outcomes of surgical procedures with resident involvement is less clear. Across the board, residents in general surgery and GYN surgery increase operative times, with or without, depending on the study, increasing post-operative complication rates. This was particularly interesting with regard to laparoscopic sacrocolpopexies. Because there's a steep learning curve for this procedure because it is an advanced procedure that requires about 25 to 30 procedures to develop proficiency, even for skilled providers. And because there was a study that came out in 2019 that indicated that resident involvement in urogyn procedures increases operative times but not postoperative complication rate. The limitations of the studies out in the literature already was that much of the data is drawn from the National Surgical Quality Improvement Database, which only follows patients for 30 days and does not delineate the amount of the procedure that the resident is allowed to perform. For example, we see in a lot of these studies that senior level residents increase operative times, whereas junior level residents do not necessarily, indicating they might perform a smaller fraction of the case. Our primary objective was to compare our operative times and surgical outcomes here at an institution with significant resident involvement to that published in the literature for laparoscopic sacrocolpopexies. We did a retrospective cohort study of 181 patients that underwent this procedure, laparoscopic sacrocolpopexies, between 2014 and 2019. After IRB approval was obtained, we extracted relevant data from the medical chart and used descriptive statistics to analyze the data. You'll note here in Figure 1, the vaginal cuff with the Y-shaped polypropylene mesh affixed. This is prior to attaching the tail of the polypropylene mesh to the sacral promontory. In Table 1, you'll note our demographic data. The average age at time of procedure was 68 years, average BMI was 28, average number of vaginal deliveries was 2.8, and preoperative prolapse stage on our preoperative exam was 2.53, and about 35% of these patients had failed prior prolapse surgery. 142 of our 181 patients came in with post-hysterectomy pelvic organ prolapse, and 99 of them had laparoscopic sacrocolpopexies without concurrent procedures. If you look here in Table 2, you're going to note our immediate postoperative complications and our intraoperative complication rates. So we had a cystotomy rate of 2% in this case series, which is lower than that documented in the comparative studies, which often range between 1 and 10%. We had no cases of enterotomy and a 3% UTI rate, which is within the range noted in the literature. We had one case excluded for conversion to laparotomy and no cases of intraoperative or postoperative transfusion requirement. In Table 3, we have our delayed postoperative complication rates. Our mesh complication rate was 1%, noting a 1 mesh detachment rate from the sacral promontory, no cases of mesh erosion, compared to 2.9 to 4% noted in the literature for mesh erosion. We had an 8% risk of recurrent prolapse during this time frame of 253 days on average that our patients were followed up for. This is compared to the study in the middle column that had patients followed up for an average of 8 months and 30 days in the far right column. So our 8% recurrent prolapse rate is lower than that noted in the literature at 14.2%. If you look at our Figure 2 on the right, this is the percentage of recurrent prolapse cases in the gray. The 54% was noted to be the posterior compartment, which is consistent with the posterior compartment as being the location of recurrent prolapse for laparoscopic sacrocolpopexies in the literature. We had one case of small bowel obstruction, lower than the 2% noted in the literature, and we had no cases of surgical site infection. If you look at Figure 3, we're looking at our comparative operative times, so that noted in the literature. In light blue here, you see our average operative time for laparoscopic sacrocolpopexies alone, 140 minutes, compared at lowest in the literature to 196 performed by attendings only in a study, and their residents took about 200 minutes on average. The studies noted 196 to 220 minutes on average for laparoscopic sacrocolpopexies without additional procedures. Our operative time for laparoscopic sacrocolpopexies with hysterectomy was 176 minutes, which is favorable when compared to those in the literature, which are noted in the bars here. Our average anesthetic time was lower than that documented in the literature as well, as you can see on the far right here. So overall, this study indicates that residents can be involved heavily in the operative procedure for laparoscopic sacrocolpopexy with favorable immediate post-operative outcomes, intraoperative complication rates, and delayed post-operative complication rates, including recurrent prolapse and reoperation rate for prolapse. In addition, we noted that our operative times, even with significant resident involvement, were favorable compared to those published in the literature, indicating that residents can be involved also in timely surgeries for laparoscopic sacrocolpopexy. Thank you.